Greetings and welcome to this video on Medicine Beyond Harrison's, where we discuss the Clinical Pharmacology Series. In this video, we'll discuss about the antidepressants for inpatient management in general medicine wards. We will discuss, and you'll get after this video, you'll know the physician's guide to prescribing safely antidepressants in the wards. It's completely for educational purposes. This is Medicine Beyond Harrison's. Let's get started. So we'll discuss the main five antidepressants that is used in the world, excluding fluoxetine, paroxetine, venlafaxine, and duloxetine, which is used for other uses. And the goal is to know what the general physician usually prescribe in the ward for acute initiation. So the five core drugs that is used are Sertraline, which is an SSRI, Escitalopram, which is an SSRI, Mirtazapine, which is a non-cholinergic specific serotonergic antagonist, Trazodone, which is a serotonin antagonist reuptake inhibitor, and Amitriptyline, which is a tricyclic antidepressants. So overall, the best drug is the Sertraline, which is the safest, and also you consider to be the first line drug. Next one is the Escitalopram, which is also a very well tolerated drug. Mitas has a specific use cases for insomnia. You can give it today to induce sleep for that patient if they are a bit agitated, insomniac, and also it is used as an appetite stimulant in case of cancer patients where the patient is having depression and they are cachectic. You can give this drug to increase the appetite and also increase the weight. Trazodone is used mainly as a sleep drug. Amitriptyline is nowadays because of the lot more side effects. It's now narrowed down and it's used only for pain management in the neurologic pain management only as in a low dose setting. So before you prescribe an antidepressant, you must know the framework, whether it is a true depression or it is an adjustment disorder to the wards or ICU setup, or it's just anxiety, or is it delirium, it is steroid induced. So in all these other cases, antidepressant is not preferred. So consider using an antipsychotic drug for use case and for sudden delirium or sedative drug for inducing sleep. Always avoid misdiagnosis, the wrong drug plus wrong expectations. Is the patient suicidal? Yes, the psychiatrist must co-manage. If target symptom is mood and anxiety, SSRI is preferred. Insomnia and weight loss you have to address, then mirtazapine is considered. If there is severe insomnia, trazodone is preferred. If neuropathic pain, it is tricyclic antidepressants as we discussed previously. So comorbidities, in case of heart disease, avoid tricyclic antidepressants, causes autonomic disturbances, tachycardia, retention of urine, and QT prolongation. So avoid escitalopram also for more than 10 milligram. You need to avoid QT prolongation. All these SSRI will worsen hyponatremia with causing SIADH. Hepatic dysfunction, reduced dose of all antidepressants. So medications such as linezolid, tramadol, there is high risk of serotonin syndrome. So for pain in case of the patient having depression, avoid tramadol. And also for skin and soft tissue infections, if you are considering use of linezolid, avoid linezolid. You can use clindamycin instead. In case of usage with the NSAIDs, there is high risk of GA bleed in case of SSRI. So avoid use. QT prolongation drugs such as beta blockers avoid. There is a more additive risk in case of usage of antidepressants. So if you want immediate help, that is if you prescribe the drug today and you want immediate action today, then use case is mirtazapine or trazodone used for both sleep and anxiety. If you want help within weeks, then SSRI is preferred. Its onset is delayed up to 2 to 6 weeks, then it works slowly. So sertraline, it is the main workhorse in a general physician. It's most useful antidepressant, safest in cardiac disease. Most of the patient admitting in wards in general medicine will have some of the other cardiac issue, and you can use sertraline with confidence because it is cardiac safe. It is first line in almost all guidelines. For major depressive disorder, for generalized anxiety disorder, panic disorder, PTSD, inpatient use, post-MI depression, hospital anxiety also you can use sertraline. So main contraindication is along with monoamine oxidase inhibitors, linezolid, methylene blue, and in case of hyponatremia, avoid usage of sertraline. Unstable GE bleed and severe hepatic impairment also you avoid using sertraline. All these will exacerbate the issue. Sertraline will exacerbate the issues of hyponatremia, GA bleed, and severe hepatic impairment. We can use following post-MI, which is the preferred and the safest drug. It has a very low QT prolongation risk. It is adjusted, no dose adjustment is needed for renal failure. Monitor sodium every second day in case of sertraline for the initial few days. Then later, third week or every fourth week. Dosing strategy start low with 25 milligram per day for 3 to 5 days. Then you can go titrate up to 50 milligram per day. Post MI start 25 milligram titrate slowly. The side effects are mainly GA upset, which is transient. There may be insomnia and sedation mix and sexual dysfunction. Always avoid usage of sertraline in severe hyponatremia, uncontrolled GA bleed, and patient needs rapid relief, that is tonight. Because it works slowly, it will not give a rapid relief tonight. Suspected bipolar, avoid usage of sertraline because it may lead to mania. Escitalopram, it is another one good tolerable drug, the most well tolerated antidepressant, slightly more sedating than sertraline. Best for generalized anxiety disorder in elderly patients. The catch is QT prolongation. The baseline QTC, if it is more than a 480 to 500, avoid usage of escitalopram. Multiple other QT prolongation drugs, avoid combining use with these drugs with escitalopram. In case of severe hepatic impairment, also avoid usage of escitalopram. Escitalopram, it is started at a low dose of 5 milligram per day for 3 to 5 days, then titrate up to 10 milligram per day. The maximum ceiling dose is 20 milligram. In case of elderly and hepatic, it is just 10 milligram because of high QT prolongation risk, which may lead to ventricular tachycardia and sudden cardiac death. So, if the patient is having high anxiety and activation on sertraline, switch to escitalopram, 5 to 10 milligram. Smoother tolerability profile is there with escitalopram. Mirtaz, it is a noradrenergic specific serotonergic antagonist drug. It is also called a Swiss Army knife because it has multiple roles. It acts immediately. That is, if you keep today, it acts today. It is having high sedative potential and appetite stimulant. Very useful in medicine wards. Major. It's used for major depression with insomnia, depression with weight loss, anorexia in case of cancer patients, cancer-related mood issues, adjunct to SSRI for sleep. Here the mirtazapine is used. It is strongest at the lowest dose. Even at the lowest dose of 75 milligram, it has a very high sedative effect. There will be weight gain because of increased appetite. There will be dry mouth and dizziness as side effects. Rarely, it can lead to agranulocytosis. Hence, check CBC if there is a fever. So, excellent use case in case of cancer and elderly patients. Obesity and metabolic, if it is a patient is obese, try to avoid mirtazapine because it worsens the complications. Renal failure, reduce if GFR is less than 40. In case of obstructive sleep apnea, try to avoid mirtazapine because of high sedative effect. Okay, you can start mirtazapine at a dose of 7.5 milligram HS and can go up to 15 milligram per day. Lower doses are more sedating because of histaminergic action. Higher doses are more non-adrenergic. So do not use in very obese patients. Severe daytime sedation needed in rehabs. OSA with uncontrolled apnea and needed to be fully alert the next morning in such scenarios because it may lead to grogginess. So all these kinds of patients try to avoid mirtazapine. Trazodone is a serotonergic antagonist reuptake inhibitor. It is a sleep-inducing agent, preferably more than an antidepressant. Best sleep-inducing antidepressant used by the physician. It can be used as for insomnia in medical patients for off-label. Also used for agitation in elderly at lower doses. Uh, Contraindication is based on prolonged QT, severe hypertension, recent myocardial infarction, and possible history of priapism in the past. Trazodone start at a low dose of 25 milligram once and at night may increase go up to 100 milligram per day. Patient rarely use antidepressant doses. As it can go antidepressants, it can go up to 300 400 milligram per day. The main risk and side effect of this trazodone is it causes orthostatic hypotension and high fall risk and is avoided in elderly patients. It has a high sedative effect and the next day grogginess. It may lead to QT prolongation and priapism, which is rare, but always you must warn the patients regarding priapism. Amitriptyline, it is previously one of the most sought of drugs. Nowadays, it's become a very dangerous tool because of a lot of side effect profiles. It is for low dose. It is indicated nowadays for chronic neuropathic pain, migraine prophylaxis, IBS, in pain predominant subtype, and tension type headaches. Okay, it is very lethal in overdoses, so always use with caution. Dangerous in cardiac patients because of QT prolongation and dangerous in elderly patients also. So always it is a strong contraindications in recent MI, arrhythmias, left bundle branch block, long QT, in case of past history of urinary retention or urinary tract infections, in elderly patients having benign BPH, angle closure, glaucoma, epilepsy, all these patients try to avoid amitriptyline. So elderly trap, strong, it has a strong anticholinergic effect such as it causes confusion, it will cause delirium. Also, although the patient is in ICU which causes delirium, amitriptyline induces furthermore delirium may lead to fall, it may lead to constipation, it may lead to urinary retention. So avoid any hospitalized elderly amitriptyline at all costs. So it can go from 10 milligram HS to 20 milligram HS. Rarely it's used more than 50 milligram in medical practice. Only psychiatrists will initiate a dose of 50 to 150 milligram. So it is safe in renal failure, avoid in hepatic impairment. In severe impairment only, in case of mild hepatic impairment, you can still continue using amitriptyline. So just a comparison, sertraline is majorly used for depression and post-MI. It's a very good drug. Avoid mainly in hyponatremia and It is the safest drug in the cardiac disease, post-MI depression. Escitalopram use cases are anxiety and in elderly. The disadvantage is the prolongation of QT. It is the most tolerable antidepressant drug. Mirtazapine, it has specific use cases in case of cancer patients, psychiatric patients, post-cancer, low mood patients. In those cases, it will also treat the insomnia as well as increase appetite to some more weight. Avoid in obesity patients, and it is sedative plus weight gain drug. Trazodone is mainly used for inpatient insomnia. At higher doses only, it is used as an antidepressant. Because of high fall risk and QT prolongation, it is not much used, but it can be used as a sleep agent. Amitriptyline, it is mainly used in nowadays for nerve pain. Cardiac and elderly patients, you have to always avoid amitriptyline. The key feature is the side effect of anticholinergic effect. So, how a physician should think about the use case of antidepressant? If the patient needs sleep at night, even though you have given a sedative drug, the patient is not sleeping, then you can for metacillin 75 milligram HS or trazodone 25 milligram HS. Plus, it acts full day itself. So, not SSRI because it acts only 2 to 6 weeks later. So in case of moderate depression, you can always use Sertraline 25 milligram for 2 to 5 days, then convert into 50 milligram. You can add Mirtazapine only for sleep. Low appetite and if the patient is having weight loss, Mirtazapine is the ideal drug. It treats mood plus sleep plus also takes care of the nutrition aspect. So in case of coronary artery disease post-MI patients, Sertraline is the best drug, evidence-based because it is cardiac safe. If there is multiple other QT drugs, prefer Sertraline, avoid Escitalopram and Trazodone. In case of elderly and frail patients, avoid Amitriptyline, high-dose Trazodone, prefer Mirtazapine or low-dose Sertraline. So hope you learned practical aspects on antidepressant therapy used in the ward cases. So these are the takeaway points. Thank you for watching. This is Medicine Beyond Harrison. We'll meet in the yet another video on clinical pharmacology series. Thank you.